But it's a great pleasure to introduce Carol Tannahill because of, in fact, it was work that Carol's centre does in Glasgow that I quoted, the difference in life expectancy between Lenzie and Calton came out of that centre that I quoted at the time of the WHO Commission, trying to make the common cause between inequalities within rich countries and inequalities between countries. So I've learned so much from what's happened in Glasgow, and I'm hoping to learn more.
Great. Good morning, everyone. I think I shall take on the task of formally thanking our last speaker. What a fantastic opening to the morning, so thank you so much. It's a real pleasure to be here. I have to say, when I was asked if I would come and speak this morning on the issue of from adversity to well-being, how communities thrive, my heart sank a bit, because in the 2 weeks prior to that invitation, I had been in meetings that had spent far too long trying to define what we mean by adversity, trying to define what we mean by well-being, and trying to define what we mean by communities. And so I thought this is probably not going to be something that I want to spend a lot more time of my life doing, but I was reassured that I was going to be in a room of people who were here because they really recognise the importance of this set of issues and they really want to make a difference. And having been reassured about that, it really is a pleasure to be here. And what could be more important, and where could it be more important than in Scotland? This trend graph may well be one that some of you have seen before. It shows the trend in life expectancy in Scotland compared to 15 other European countries. And what is particularly striking is that until about 1950, Scotland was kind of middle of the pack. Our life expectancy was very similar, average, for the whole of Europe. But from 1950 onwards, our position has declined compared with other European countries. And since 1990, we have, in fact, the lowest male life expectancy in the whole of Europe. And so it's a question for us all really to understand why that is. And so the first thing that one might do in this situation is look at how the causes of death have changed over this period of time. And this figure shows the contributions to the 100% of deaths, if you like, that take place in Scotland, and how those have changed in the last 50 or so years. Now, you'll not be able to see the code here, but hopefully you'll be able to see the colours. And what is, I think, apparent very easily from this graph is that those two blocks, the one in the middle that's a slightly sort of mauve shade and the one that's dark blue, remain the main contributors to Scotland's mortality, but their proportion has declined over time, and they are, of course, coronary heart disease and cerebrovascular disease. But the two colours that have grown in their proportionate contribution to all of the deaths in Scotland over this period of time are in pink and in yellow. And these are deaths caused by alcohol misuse, drug misuse, and external causes. So when we look at what is contributing to the loss of life in Scotland, these are the issues that are becoming increasingly important. And to pick up Sir Michael's theme of the relationship of overall health to health inequality, this is a single figure that reflects the body of work that my colleague David Walsh has led on, looking at the causes of Scotland's excess mortality. That is, the amount of death that happens in Scotland over and above that which we would expect given the age and socioeconomic composition of the population. And it compares Glasgow with two cities that are entirely comparable to Glasgow in their history, in their socioeconomic status, and broadly in their size and position in the country, Manchester and Liverpool. And what you see here is, again, that the main causes of the excess that we see in Glasgow sit on the right-hand side here: drugs-related deaths, alcohol-related deaths, deaths from suicide, and deaths from external causes, most significantly violence. And the figures here are really high. So Scotland has about 150% more deaths from drug-related poisonings than do the people in Manchester and Liverpool. And you can see the comparable figures for the other issues. So this is an incredibly important agenda and challenge for all of us who are concerned with social justice, who are concerned with the country's health, to really think about what our strategy should be to impact on these very large excess mortality figures. So why do the early years matter? Sir Michael has given us a tour de force of understanding that, and I'm sure we're going to hear more again as the day goes on. So I'm just going to cover this very briefly. But the Lifecourse effects, this has come up slightly different than expected. Lifecourse effects of early adversity on health are multiple. So there are strong and graded associations between childhood adversity and the risk of adult drug and alcohol misuse, suicide, smoking, obesity, physical inactivity, sexual health problems, mental health problems, and adult diseases. Across a whole range of factors, early life adversity has an impact. But over and above these things that are often talked about and measured, there are some other things about people's relationships that are very apparent on the basis of exposure to childhood adversity. So childhood trauma is associated with lack of empathy and the emergence of behavioural problems. Adults who perpetuate violence on partners are more likely to have witnessed violence themselves as children. So we're seeing this intergenerational effect. And of course, the effects of ACEs in adulthood then translate into adverse experiences for those adults' children. And these are not random effects. They're the predictable consequences of the damage done to child development, and they accumulate across the life course. The ACEs literature, which I think most people in this room will be familiar with, has brought a lot of this into sharp focus by focusing particularly on adverse childhood experiences, discrete, measurable adverse childhood experiences to do with abuse, neglect, and household adversity. And the key thing here is that these experiences can affect anyone. They have a range of impacts similar to those that I've shown in the past slide, and they have cumulative effects. However, the harm is not inevitable. And I put this slide up because we can see two things happening at the same time. If you're used to interpreting these sort of blot diagrams or this sort of image, if you look at it, you can see one set of things, which are the vases, and if you look at it in a different way, you can see a different set of things, which are people's faces. Do you get that? Fantastic. Okay, and this one isn't in colour, so I don't have to worry about colour blindness or anything here. So what I want to do is to try and keep both of these in picture at the same time. So looking then at the positive benefits of a good start in life, and again the Minister has emphasised these, and it's this perspective that has been central to our National Performance Framework and the outcome in the National Performance Framework, which is that all our children should grow up feeling loved, safe and respected. And achieving that as an outcome embedded in Parliament, supported by all of Parliament, was quite a difficult challenge. Because you can imagine ministers standing up saying, I want loved to be part of this outcome, and people saying, well, how are you going to measure that? And ministers saying, well, it's hard to measure, but it's probably the most important thing. So we're going to have it as part of the outcome. We're going to say our outcomes are about what matters, not just about what's measurable. So if we start young, it doesn't guarantee good outcomes for everyone, but it's associated with a range of personal and social benefits. Good parenting of the next generation, healthy child and adult populations, education and skills attainment, economically active adults, responsible citizens, reduced crime, and resilient individuals and social networks. If we get things right in the early years, we'll not only help prevent some of the consequences of adversity, we'll help to produce a range of very positive outcomes. So I've been asked today to talk about what a public health approach might add in this context. So I think many people in the room will be familiar with what public health is, but it's worth just clarifying a couple of points on this slide. It's the science and art of promoting and protecting health and well-being through the organised efforts of society. Public health is not something that any one individual or any one professional group can do. It's about organising our collective efforts to the same end. It's population-based and it's long-term. And it recognises, as Sir Michael has said, the role of the wider determinants of health and disease. So, if we're concerned with the factors that make populations healthy, what are those factors? And this is one way of representing the factors that produce healthy outcomes or unhealthy outcomes in a population. It's developed by two Americans, Evans and Stoddard, and I put it up because it illustrates two things quite clearly, I think. The first is that the role of services, put up here as healthcare, is part of the system, but is not the primary driver of the outcomes of health and function and well-being. Those primary drivers sit in the big boxes at the top: the social environment, the physical environment, and prosperity, or the economic environment that comes up from the bottom right-hand corner and influences everything else you see in this diagram. Now, on the left-hand side, you see the issues of individual response, biological and behavioural. And it's those individual responses that we're often observing in our communities as a consequence of the adversity in which children are being brought up and the issues they're experiencing in their lives. Now, I'm often asked, does that framework of what makes a population healthy apply also to what makes children and young people have good outcomes? And yes, it does, but the focus in these boxes would be slightly different if you're focusing particularly on outcomes for children and young people. And this is a summary of work that Sarah Dodds carried out when she was with us at the Glasgow Centre, bringing together our evidence about the impacts of a range of factors on children's outcomes. And you can see here that within the social environment, crucially important are the family and parental environment and the learning environment. But the impacts they have are affected by the wider neighbourhood environment. Again, Sir Michael has made this point, and fundamentally the socio-economic context in which people are being brought up. So, a whole system approach is needed, working across all of these levels or across that set of boxes in the Evans and Stoddard model. And I want briefly to say, what does that mean for how we move forward together, and what opportunities are there for us in Scotland? So this is the traditional way of looking at the outcomes in our communities. These are data from community profiles. You can access them on the Scottish Public Health Observatory website. These are two contrasting communities in Scotland. The middle line represents the Scottish average for any of the dimensions on these profiles. The bars going to the left represent something that's rather better than the Scottish average. The bars going to the right represent things that are rather worse. And each bar represents a different dimension of community life. So it might be the level of employment, the level of educational attainment, the quality of the green space in the area, the percentage of people smoking, the levels of child poverty, etc. And when you look at this, it is so striking just how different the experience is of people living in two contrasting communities in Scotland. But the key question is, what do we do about that? And the traditional approach has been to implement programmes that try to move each of these bars separately from the right-hand side over to the left. So we implement educational programmes, we implement literacy programmes, we implement smoking cessation programmes, etc., etc. And to an extent, that works. But again, as Sir Michael has said, the factors that perpetuate these differences are not those that are about individual issues. They are factors that cut across the whole set of issues on these profiles, and adversity is one such factor. So what might be an alternative approach to try to make the red community more similar to the one at the top of the graph? We've been working on this concept of children's neighbourhoods for Scotland. It's a relatively new approach, but what it is doing is adopting a place-based approach specifically focused on improving outcomes for children, and implementing this approach in some of the areas of the country that have the highest levels of child poverty. So it is not a new initiative. What it is about hearing from children and young people in those areas about what the assets are in the area that really matter to them, and what their needs are that they want addressed. It's about working with frontline staff to achieve collective impact on those issues, using the resources in the area differently to improve outcomes for children. And it's about drawing on international experience from New York City, from Chicago, and also internationally from children's neighbourhoods and children's zones in England. So we have a lot of interest in this approach. We've started implementing it in the East End of Glasgow. We're going to be rolling it out to 6 or 7 other neighbourhoods in Scotland. And we're really absolutely committed to making sure that issues of adversity are at the centre of what we do in children's neighbourhoods. If anyone in this room is interested in the approach and how it might support the work you're doing on ACES hubs, then we'd really welcome a further conversation about that. The other thing I want to say about this issue of inequality in children's neighbourhoods is about the importance of recognising insecurity as well as inequality. And these are data from growing up in Scotland, looking at levels of child poverty in Scotland. And we can see here that about 25% of children were in persistent poverty. But actually, you have about 15% in recurrent poverty, going in and out of poverty, and you have about another 15% in transient poverty. And there's a lot of literature that shows that this uncertainty, this insecurity, is actually almost as bad for people's health as the sustained experience of poverty and inequality. And I think that's one of the reasons too why adverse childhood experiences has become such a powerful language for us all, because it makes us recognise that actually adversity doesn't need to be something that is sustained over time for it to have an impact on us. You can have experiences that occur at one point in your life that have got long-term implications, even if the rest of your life wouldn't represent adversity. So, what do we need to do? We need to invest in building resilience in communities. Resilient infrastructure, it takes different types. This is how it's often thought of. It's often thought of as being about transport, communication, resilient buildings, etc. But for us, the social stuff forms another type of infrastructure that is crucial for the resilience of children, families, and communities. Invisible threads are the strongest ties. I think that's a really nice concept, and it's one that I think is at the heart of our Scottish response to adversity. Some principles to apply, you can read this for yourself, but if you're really focusing on how we build resilient communities, the literature would suggest 5 aspects that should be front of mind in all that we do. Meet basic material needs, build capacity and engage, do with not to, invest in communities, don't take out from communities, coordinate and create linkages, foster social capital, and develop governance structures that don't depend on detailed plans. It's an interesting one, isn't it? We're often asked, so what exactly are you going to do? The key thing here is to do all of the above, and that to be your plan, and then to be responsive to what emerges from that. Don't try and plan it all out in detail from the start. So as well as building resilience, keep a focus on preventing and mitigating adversity. This slide from the Early Intervention Foundation shows the costs to society. These are the financial costs. We've talked earlier about the human costs of not investing in prevention. Huge sums of money spent dealing with the consequences of adversity and the failures of shifting inadequately to prevention. So again, just referencing Sarah's work, if we are going to shift to prevention and we're going to prevent and mitigate adversity, what are some of the things that are really going to make a difference? And these 5 balloons summarise what we've found in the Glasgow Centre for Population Health. Adequate family income and actions to mitigate the impacts of poverty and inequality. Strong bonds and positive relationships with caregivers and across schools and communities. Nurturing approaches to help children heal from adverse experiences. Safe home, school and neighbourhood environments involving children and young people in decisions affecting their life. Okay, so 5 foundations for enabling children to have a good start in life. I think I'm short of time, so I will just rush on. I just want to pause on this. Safe environment, broadening our perception of what child protection means. Really important. Child protection often talked about in a really narrow way, but is this giving children a safe environment to play? No. Is this, I guess it's Fiona Crawford's work, is this actually providing the sort of opportunities for children to eat healthily? Yes, it's not as simple as individual choice, but if local shops are actually promoting really unhealthy options at reduced price, specifically at school lunchtimes, that is not protecting the health and well-being of our children. So, systemic infrastructure, we've got the message, we got it from the Minister, we got it from Sir Michael, that this is about working across systems. And I just wanted to leave you with some thoughts about some of the things that we might need to attend to collectively as we do that. Because we can talk about systems as though they're abstract things, not living and breathing things. But these set of ideas are helpful in encouraging us to attend to the housekeeping work of working systemically. So what's the circulatory system? What's going to flow around your system? And how is that going to work? What do you need to share and what information do you need to flow around? What information do we need to collect and from where? What are we sensing? What are we hearing? How are we going to nourish our system, our public health system, keep it healthy? What's that about? Making sure that we're all replenished, that we have the training and development that we need, that we have the recognition for the difference that we're making. What structures are going to hold the system together? It's not going to happen just because we've got goodwill to do it. We need some sort of structures to do it. And how will we develop effective relationships, establish common values, and contribute to wider societal goals? So I think we'll continue to hear a lot about systems-based working today. And I just want us to think about the housekeeping to make sure that that systems-based working is healthy. And I'm going to give the final words, not to Margaret Mead, as the Minister did, but to another MM, Michael Marmot. And he was saying here in his Fair Society Healthy Lives report that the link between social conditions and health is not a footnote to the real concerns about health, healthcare and unhealthy behaviours. It should become the main focus. And in the context of today, our interest is in how these social conditions can help mitigate and prevent experiences of childhood adversity. Thanks very much.